Welcome, everybody. It's 4:30. I can see that all of the board members who are planning to attend tonight are here. So, Renee, if you could just begin the roll call, please.
Yes, so please state present after your name is called. Representing Adams County on the Board of Health, Julie Mollica.
Present.
Rosanna Reyes.
Present.
Julie Schills. Julie Schills.
I think Julie was unable to attend tonight, Renee.
That's right. She's out of town. Representing Arapahoe County on the Board of Health, Jan Brainerd.
Present.
Dr. Thomas Faywell.
Present.
Dr. Kaya Gallagher.
Present.
Tri-County Health Department Leadership, Michelle Askenazi, Director of Emergency Preparedness, Response, and Communicable Disease Surveillance.
Present.
Heather Baumgartner, Director of Community Health Promotion.
Present.
Lisa Bolstad, Administrative Assistant.
Present.
Jill Bonchinsky, Director of Nutrition.
Present.
I'm Renee Brockman, Executive Assistant. Monique Didier, Director of Administration and Finance.
Present.
Dr. John Douglas, Executive Director.
Present.
Maine Furman, Director of Human Resources.
Present.
Penny Grandy, Director of Nursing.
Present.
Brian Halavasek, Director of Environmental Health.
Present.
Jennifer Ledwig, Deputy Director.
Present.
Dr. Kelly Weidenbach, Director of Planning and Information Management.
Present.
The roll call is now complete.
Thank you, Renee, and welcome, everyone. Did the Tri-County team have anyone that they would like to introduce who is attending our meeting tonight?
I'd like to introduce Dr. Maura Proser, who's going to be joining us for a presentation on flavored tobacco and nicotine products.
And I'd like to introduce Alex Kellogg. She is our new COVID-19 Partnerships and Strategies Program Manager, and she will be joining us in the event there are additional questions during John's COVID update.
Great, thank you. Welcome all. Just a short reminder to the Board of Health members, please use the chat function or raise your hand if you would like to ask a question or make a comment. And for those members of the public who are attending tonight, we encourage anyone who has questions to go to the Tri-County website, which has updated guidance documents as well as answers to frequently asked questions. The website also contains dedicated issue briefs on topics such as vaccines, testing, and issues specific to businesses and schools. If you can't find the information you need, there are also Tri-County contact numbers listed on the website that you could use. During tonight's meeting, any members of the public who would like to make a comment addressed to the Board of Health can use the question and answer function. After the meeting is over, I assure you that all of your comments will be compiled and shared with the Board of Health members. Moving on to the action items on our agenda, as a first item of business, the board needs to approve 3 sets of minutes. Do I have a motion to approve the minutes from November 22nd?
So moved.
Is there a second?
Second.
Thank you. Any discussion? All in favor, please say aye.
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 Anyone opposed? Great, thank you. The motion carries. Do I have a motion to approve the minutes from December 9th?
So moved.
Is there a second? I'll second. Is there any discussion? Hearing none, all in favor, please say aye.
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 Anyone opposed? Motion carries. And finally, do I have a motion to approve the minutes from December 20th?
So moved.
Is there a second? Any discussion? Great, thank you. All in favor say aye.
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 Anyone opposed? Motion carries. And thank you, Renee, for, as usual, your diligence in compiling those minutes. They're terrific. As the next item, the board will vote on the locations for the posting of public meeting notices. Before we actually move to have a motion, Renee, can you give us some background on this topic?
Yeah, so basically, and to put it simply, we post all of our Board of Health meetings on the Tri-County Health Department website in accordance with the Colorado Open Meetings Law.
And every year we have to approve the location of those notices?
That is correct. It requires us to approve that at the first meeting of every calendar year.
Great, thank you. Do I have a motion to approve the locations for the posting of the public meeting notices?
So moved.
Is there a second? I'll second it. Any discussion? Any questions? Hearing none, all in favor, please say aye.
Aye.
Aye. Anyone
Aye.
opposed? Anyone opposed? The motion carries. Thank you. As our first information topic, Maura Proser will provide an overview of issues related to flavored tobacco and nicotine products. So thank you, Maura, once again for showing up and giving us another very informative briefing.
Hey, if I could, I want to thank Maura for joining us on short notice, and I wanted to also acknowledge that we are trying, even though you're going to hear a lot from me about COVID tonight, to sort of rebalance how much the board has a chance to hear about things besides COVID, of which there are plenty. This topic came up at our legislative panel that we had, gosh, I guess it was last week, important topic, and I just wanted to thank Maura for helping us talk about this on short notice.
I'm always happy to come and speak and share really about the great work that's happening, not only to represent the team that I work with and let you know all the great work that they do, but really there's a movement across the country, across the state and across the country to talk about broader tobacco issues. We understand that we have dropped the smoking rate in this country dramatically from when every adult smoked and you could smoke in restaurants, and we've really changed the social norm to where smoking is no longer the norm. And we have dropped smoking rates. We're about 15% for adults and about 5% or less for high school students of smoking in Colorado. And we recognize that we need to do something to reach that last 15%. And what we know that's different about that last 15% is we are primarily talking about those who are still using tobacco products, specifically smoking, remain individuals with low educational achievement, low income, and communities of color. And I'll talk a little bit about why that is. So I'm gonna share my screen. And I'm going to speak a little bit about flavored tobacco and nicotine products. I want to point out that this photo is from an advertisement that we ran many years ago. One of our first media campaigns with the Tobacco Control Grant was the Sweet, Cheap, and Deadly campaign, really trying to highlight that tobacco products come in very sweet flavors that are attractive to young people, and they're very cheap and easy to buy. This photograph was taken in a convenience store along Colfax by one of the youth participants in our program. So this is a very Aurora specific and really local. You'll see this anywhere, not just in Aurora, to see that photo. So what are flavored nicotine products? They're exactly what you think they are. They are tobacco that's made to look like candy. The intention is if we can mask the flavor of tobacco. I have never used tobacco, but from what I hear from colleagues and others who have tobacco is pretty gross tasting. So if you can mask that with apple or cherry or menthol, it makes it easier to go down, and it makes it actually taste good, and it makes people want to use it. You'll hear this a lot as an issue when we talk about young people. Flavors are a way that young people get hooked, especially flavored vaping products. These data are national data. We don't have a lot of usage data for Healthy Kids Colorado data. We do have about, I'm going to forget the number now. It is less than a third, of young people who vaped in 2019 specifically said they did it because they came in flavors. But we know that they were, it's not, that's the only question we have about flavoring is why they're doing it. But we do know that more than a third of young people who are vaping and using other tobacco products are using flavored products. So nationally, 81% of young people who have ever used a tobacco product, they started with a flavored product. It makes it easier to try and it makes it easier to go down. In 2020, these are 2020 national data, 87.5% of young people in the US who vaped used a flavored vaping product. So that's nearly all. And fruit, mint or menthol, and then candy or other sweets were the most common flavors. So we're talking about more than half are using mint and menthol, 71% are using fruit flavors. And we know that this is how young people are becoming addicted. That's how they're being drawn in. We often hear things like, we know that adults use mint and menthol, but, unicorn fart flavor, things of those nature, those are for young people, and candy, those are truly to attract young people. So we cannot ignore that impact, the fact that this really has an impact on young people. But more importantly, to understand when we're talking about flavored tobacco products, specifically mint and menthol, is that it truly is a social justice issue. All of the tobacco documents that were released during the time of the Master Settlement Agreement back in the 90s really showed that for decades, the industry was targeting specifically communities of color with menthol cigarettes. They knew that this was their chance, and communities of color are heavily targeted. And if you were to compare, if you were to go to a low-income community with primarily residents of color, for example, in North Aurora, that convenience store is going to look very different and have very different advertisements than a convenience store that you're going to find in Greenwood Village or Centennial. So again, we have seen there have been multiple reports. The Big Tobacco has targeted specifically African Americans with ads for menthol. They knew that this was their prime audience. You probably have seen some of these ads. What the idea was that we're going to find Black artists, we're going to find Black artists to promote, Black professionals to promote, and there's really a lot of talk around appropriation of Black culture and really trying to show menthols. Newport is a menthol only brand. Really show them as cool and as being part of the culture. So this is what we're seeing, and this is what we have seen for years. I'm sure you have seen some of these, and you can see that this is a range of ads, some of which are still relatively recent. These are not just very old ads from the 50s or 60s. And in your packet, you have a timeline. There was a fact sheet that was included in the packet that really talked also about the targeting across the decades. So nationally, 89% of African Americans who smoke menthol. And that's not an accident. That is exactly what the industry wanted to happen. Some things to know about menthol is that it makes it a lot easier to go down. That mint flavoring makes it smoother on the throat. If you have ever smoked, it's especially like straight up tobacco, it's really harsh on your throat. The mint and the menthol, think about a cough drop. So imagine if you smoked with a cough drop, it makes it smoother going down your throat, and it makes it much, much harder to quit. This is some screenshots of a campaign that came out very recently that our program actually also promoted, really looking at tobacco industry documents. So what Big Tobacco said about the Black community, and this has some Black actors reading these documents. One of the most famous quotes from this time is, we don't use that stuff. We just sell it. We reserve the right to smoke for the young, the poor, the Black, and the stupid. This is who they are targeting. There are documents showing young Blacks have found their thing, and it's menthol, and that's what we're gonna promote. Smoking and health is of little concern to the African people. These are lies that we all know, but the industry has been promoting for a long time. It's also come out Juul, who is famous for their USB-like vaping devices that are very easy to be used in school that used to come in a ton of flavors. They funded after school programs to allow them to gain access to children, specifically Black children. So because of this, we really are concerned not only for the impact on young people and for the targeting of young people, but we are really concerned about the targeting of our communities of color. And your packet should also have a link of some various resources that go more in depth into some of this. And really the racist roots of the tobacco industry go back to the first, the first boat that came in of enslaved Africans in 1619 came into Virginia, my home state, for picking tobacco. I mean, it really goes back to that far back. Tobacco has really been enslaving African Americans since they came in as enslaved people and were forced to pick it, all the way through the industry targeting of these communities and really kind of keeping them oppressed and enslaved through their addiction. So our recommendation, and when I say our, I mean the public health recommendation. This is a recommendation not just of Tri-County Health Department, but of every public health advocacy group and every public health recommendation. CDC would like to see this. Campaign for Tobacco-Free Kids, American Heart Association, is to ban the sale of all flavored nicotine and tobacco products. And really what that means is banning all products. So not just vape devices, but menthol cigarettes, those little cigars that you saw in that first photo. All flavors. It's really important that we include mint and menthol because this is the main product that the industry is using to target our communities of color. And really all stores and all outlets, making sure that this is something that we don't want in our community. We would like to see it really needs to be linked to a retail license, which the state of Colorado does now have a local retail license, or excuse me, a statewide retail license. So all retailers must have a license to sell. And by linking it to that, it makes it a provision of their license. If you sell flavored tobacco products, you have violated your license and it's a mark against your business license. It's very important that we want to make sure that from a public health perspective, we want to prohibit sales only. We want to really look at retailer practices and industry practices. We do not believe in laws against possession or use. We don't want penalties for individuals for having or for using, but really making sure that they are not available in our community. The anticipated impacts of this, and we've seen this in some smaller communities who have already had regulations on these sales, is an increase in successful quit attempts and reduced initiation among young people. And of course, we can't ignore the fiscal impacts. I do have to acknowledge that it would be a huge fiscal impact given how much money comes into stores on the sales as well as the revenue that we get from taxes. And that's really, I think, just a decision that has to be made by decision makers as that gets made of what is the most important thing for us. And we really appreciate the decision makers we have spoken to who have really talked about it being investing in our communities more so than anything else. 6 local communities in Colorado do have prohibitions already on the sale of flavored tobacco products. In the metro area, so far that's only Edgewater, and that's relatively new. And then the city of Boulder does also have one. Theirs is incomplete and we wouldn't consider it best practice. It's a start, but it's not complete because theirs is only on vape products. And so that really is not addressing the industry targeting of menthol cigarettes to communities of color. And it's also potentially leading young people who are already addicted through their vape products. It's potentially leading them more quickly to traditional combustible tobacco. The Denver City Council did pass a regulation and it was vetoed by the mayor, and this just happened last month. So it's kind of still new and happening. And one of the things the mayor said was really wanting to see a regional approach, which there is some interest in that, but then also the idea of state legislation. And there will be, we have heard there will be state legislation introduced this year. And there was also a bill that was proposed in 2020. In both cases, back in 2020 as well as this year, both of the sponsors were from Adams County. And that's something that we're really proud of. We have always been proud of the public health champions that we have in the legislature from all of our counties, and specifically these. In 2020, it was Representative Caraveo, who is a pediatrician. So she cares very much about health. And this year, We believe it'll be sponsored by Representative Mulliga, who is a nurse. So again, really understanding and caring about healthcare. So that is my 10-minute presentation, and I'm happy to take any questions. I wanted to get through this quickly, but this is an issue that's really, really important to all of us. And when I say us, I truly mean us. I want to give credit to the great team that I work with who helped me put this together and who's also leading a lot of the great work as well.
Great, thank you, Maura. The Board of Health will be able to follow the progress of the legislation that is proposed as part of the legislative updates that are regularly included within the Executive Director's Report. So I'm just curious whether, Maura, you are more optimistic that this year this legislation has a chance of passing.
I would like to be. I don't know enough, to be perfectly honest. I don't know enough about the current legislature who's sitting to know how it will fare. I know that in 2020, one of the concerns was the fiscal impact, right? We can't ignore the tax revenue that comes in from these products. And if I remember correctly, the fiscal impact, the fiscal note in 2020 was 50 something million. I mean, it was a huge number. And so I know that there were some exemptions and some concessions made. And so I think that there will be a lot of conversation and negotiation. And if Melissa, I think Melissa's on, if she has more insight into that, I would be happy to hear it. But I think that it has an uphill battle, but I also think that it's important enough. And we have some really, really great champions at the State House who we're really proud. We are proud to have them representing us and pushing this forward.
And Maura, I'll just add that one factor that's a bit different this year than last year is that the city of Denver passed a flavor ban and Mayor Hancock vetoed that flavor ban, saying that it really did need to be a statewide action. And so last year there was a big push to have this done at the local level. And I think the state legislature has seen that that may not be possible. And so, like Maura, I cannot predict. There are a lot of factors. And like Maura mentioned, the concessions that really can't be made in.
Okay, Melissa, I think you've cut out. If you are able to join us, raise your hand again. In the meantime, Jan, did you have a question?
I just had a question for Maura. We in the past have done resolutions, and I don't know, as a Board of Health, and I don't know if there is, and maybe Melissa would know, if there is any path for us to do this that would be helpful, whether we submit it to the legislature or just who we could support with such a thing if the board was interested in doing that.
Thank you for that question, Jan. I think that was one of my notes I was supposed to mention, and I can't see my notes when I'm presenting. Yeah, so in 2019, this board declared youth vaping a public health emergency, and it included a list of public health recommendations for a variety of stakeholders, saying these are things that we encourage all stakeholders to do, and it also put your blessing behind committing our resources as a department towards doing that. And one of those was prohibiting the sales of flavored nicotine and tobacco products. So there is precedent. This board has already said that that is something you support in communities. As far as doing anything to support this upcoming legislation, I will look to other experts on the process for that response.
Great, thanks. Let us know for sure. Thank you.
And I will also just say that, you, regardless of being on the board, you are all individual citizens, and I will assume registered voters. So everyone can and should exercise your own civic duty of communicating with your own elected officials.
Thank you. Dr. Douglas?
Yeah, just two quick thoughts. One is, I think over the last year, the recognition of the worsening of the already long existing youth mental health problem, crisis, pandemic has been further recognized. And while I don't think we could say nicotine is making necessarily kids depressed or anxious, it's clearly part of the warp and woof of substance abuse. And I'm wondering if that could create a context that might be more favorable. The second thing I would note is the bill is already being discussed by CALFO, Colorado Association of Local Public Health Officials, and it's likely to end up being one of their top legislative priorities for the year. We don't know that for sure, but I think there is CALFO doesn't, sway a lot of voters necessarily, but there will certainly be interest in a lot of places in putting some support behind this.
I'll just touch on what you said, Dr. Douglas, about the link with mental health. And I think there is more and more research coming out about nicotine's link with depression and anxiety. And that is the Truth campaign, where I stole many of these screenshots from, and would recommend you visit their website. I think it's one of the links I provided. Their newest campaign is really promoting the link between vaping and depression and anxiety among young people. You may have seen their commercials of a guy going around to convenience stores promoting the depression stick to really try to raise awareness of that link. So I think there is more research out there that could be included.
So that's why it's great for Tri-County to have experts like Maura to keep people like me oriented. Thank you, Maura.
I work with a great team.
Thank you, Maura, for that great presentation on such a timely topic. I'm not seeing any other questions, but please feel free to reach out to Maura if you want to follow the legislation, or you have any other questions or would like any more information. As the next topic, we're moving on to our COVID update. So Dr. Douglas, would you like to provide us tell us where things stand regarding the COVID epidemic?
I would be happy to for the, 20th month in a row. I already said I'd like to stop talking about COVID 24/7. And if we can get through Omicron, maybe I'll start to do that. But yeah, let me give you an update. Thank you, Lisa. And if you could go to the next slide. As I've often done, I'll give you an update on trends, where we stand with vaccination. We're learning stuff rapidly about Omicron. I'll share a little bit about some of the high points of that, some of the challenges we're having with treatment. I want to give you an update on mask mandates, and then some reflections about sort of looking forward. Lots and lots of chatter these days about new normal, getting to endemic, blah, blah, blah. And I want to sort of share some reflections about that. Next slide, please. So this is CDC data on the left, with the purple being Omicron, which the CDC model now estimates to be over 96% of all strains nationwide. So 2 months ago, we were saying it's all Delta all the time. You can see on the CDC graph, the orange bars were Delta, and we have not seen a variant go from 0 to 60 like this before Omicron. I mean, literally in 4 weeks, it went from just being detected to being pretty much everything. The right graph is the Colorado graph. Purple is Delta, turquoise is Omicron. This is actually directly measured, not modeled data. It's based on sentinel surveillance samples that are thought to be representative of the general population. And you can see the acceleration was actually even faster in Colorado. And we're now, virtually close to 100%. I mean, there's some confidence intervals around this, but it's pretty much everything we're measuring now in the community is Omicron. Next slide, please. This is actually yesterday. I sent out some draft slides the other day. I know that it's helpful to the board to be able to see these, and I tried to update as many as I could. This is looking at national data about case rates and hospitalization rates. I'm showing both of these because case rates are the metric we've been following. They probably move most real time. They are therefore most real time useful. But I think we're increasingly realizing that, especially with something like Omicron, sneak preview, you already know this, it's not as severe as Delta was. Metrics of severity have become more important. So as of yesterday, last evening, this is Washington Post tracking CDC data. Colorado had a rate that had been going up 66% in the last week. We were number 17 in the country among states. We were substantially lower for hospitalization on the right, the purple curves, 28 per 100,000. So not clear to me whether or not this represents somewhat better than average vaccination, that we're going to get cases, but maybe not quite as many will be severe, or whether it's simply a matter of time, and whether we're going to see more hospitalizations coming in. I mean, we're obviously going to see more, whether our rate's going to go up and how long it'll go up. So just to give you a flavor for where we stand with these two metrics nationally. Next slide, please. These are local data, tri-county data on the left, Adams, Arapahoe, and Douglas in blue, orange, and red respectively, and state data on the right. And I'll note to begin with that the state began to more prominently say we have case reporting lags and our data are probably somewhat unstable. And this instability was related both to the fact that an increasing but still unknown fraction of people who test positive are doing so with rapid at-home tests, much of which is not being reported because either folks don't know how to do it. I mean, my daughter, who's a public health worker, tested positive with a rapid test and spent about a half an hour trying to figure out how to report it and finally gave up. Or folks that we heard this morning on a call with Adams County don't want to let the government know that they've tested positive. And I really appreciate Dr. Albanese pointing out, we like counting cases, but the main thing is for people who have the infection to find out. And if we can find out about it as well, that's good because that helps us track and it gives us an opportunity to do some sort of a case interview. But honestly, with the number of cases that we have, and in Tri-County, we've been setting records every other day in terms of number of cases that we've seen. So like every other part of healthcare, we're doing triage right now. We can't possibly interview every case that we see. We're prioritizing cases based on interviewing the most recent cases first. We're interviewing older folks and we're interviewing younger folks. And if we can get around anybody else in the middle, we try to do that. But we are clearly in record-setting territory, and you can see the old record. These are cases again. These are not hospitalizations, but the old records from a winter a year ago, we far surpassed those with Omicron. Next slide, please. These are case rates by age, Colorado on the left, Tri-County on the right. I think the major take home of this is that cases are not at all surprising. You guys probably know this from your own family and friends and social networks. Case rates are going up in all groups. 5 to 11 and up, or 5 up, is vaccine eligible. And all those vaccine eligible groups are going up as steeply, if not even more steeply, than the one group who can't yet be vaccinated, 0 to 4. The Tri-County part of the graph is a little busier because we show you more age breakdowns. But basically the message is the same. It's adults who are increasing fastest, but our kids are going up as well. And fortunately, our oldest and potentially most at-risk groups, the 65 to 74, that's in brown, the 75 plus, that's in gray, are going up the least, but they're still going up. So no difference by age. Nobody's really being spared age-wise. Next slide, please. These are looking at school outbreak data, and honestly, they don't show you a lot compared to our board meeting in December because, schools got out for winter break and they've just gotten back in place. I can tell you we are beginning to see school outbreaks. They haven't yet been formally designated as outbreaks. You're undoubtedly reading about schools having trouble staying in session. Some of that's due to staff illness. But a lot of it's due to clusters of cases that are about to begin turning into outbreaks. And because childcare centers didn't take a winter break, really, we continue to see cases during the winter time period. Next slide, please. And as I've shown you before, this is our cumulative number of outbreaks. Remember, again, this is a really small part of the overall iceberg because you got to have at least 5 confirmed cases to be a confirmed outbreak, or you have to have 5 confirmed and or highly suspicious to be a suspect outbreak. And oh, by the way, if schools are not helping us connect the dots, and some schools were never really staffed this year to help us connect the dots. Others, frankly, were not as interested in helping us connect the dots. And then every school has been challenged with staffing recently. So please understand that the numbers you see here, which are just cumulative to give you some sort of flavor, are a very small fraction of the overall iceberg, we believe, of what's happening in schools. Next slide, please. Another way of looking at the rate stuff, I showed it to you overall. I showed it to you by age. This is by geography. These are census tracts across all 3 of our counties. Again, no geographic area spared. We see fewest cases in our rural areas on the plains. And the rates out there in Eastern Adams, 1030 per 100,000 for a week, Eastern Arapahoe, 918 per 100,000 for a week, are in fact somewhat less than what one sees in the more metropolitan areas, but not a lot less. I'll remind you that the cut point here of being in the red zone is being more than 100 cases per 100,000. So even the rural areas in our counties are really bright red. I will also note that we are seeing a rapid expansion of Omicron in different geographic areas following fast upon each other. So 3 weeks ago, where it all began in Colorado anyway, was an explosion in the ski resorts. And then the Front Range metropolitan areas followed next. I think what we're almost certainly going to see is that radiating out to other parts of the state in terms of case rates going up. For example, I don't know how many of you guys look at the CDPHE dashboards every day. I do so like clockwork. We actually have had 2 days of declining 7-day rates in our 3 counties. Now, I don't know if that's a data glitch. I was on the phone with Adam Anderson, our data czar, to figure out, is this likely to be real? What might we be beginning to see what New York City, Boston, London, South Africa have already going down? Probably too early to say yes, but it's beginning to be suggestive. At the same time, some of the counties that had not experienced it, the rise quite as abruptly, Weld and El Paso, for example, are continuing to go up. So it's spreading, and the areas that got hit hardest first, Eagle counties, for example, they were just knocked senseless by this 2 weeks ago. They're really beginning to see much lower rates. So I don't know that we're there yet, but I suspect that there will be waves throughout the state. And I hope our wave will be beginning to diminish soon. Next slide, please. Yet another geographic rate. This is actually the dial thing I look at every day. So the left is where we were. I gave a quick COVID update at the legislative session last week, and this is the graph I used. It was from January 2nd. And just look at the colors. I mean, Colorado is practically all red as of, this was Tuesday. I'm sorry I didn't get a chance to update this. It's even redder now. But you can see just how much that rainbow color has changed, going from, sort of partly red, a lot of orange, still some yellow, to just pretty much being all red across the state, really just within a week's period of time. Next slide, please. These are state data because I don't have our own local test positivity data mapped out nicely, but it would look the same. So test positivity is just like case rates have gotten into record territory. This was 2 days ago, 29% of all samples in Colorado tested positive. Adams and Arapahoe have been hovering in the mid 30s. They actually went down about 0.2% from yesterday. And I don't know whether that's a statistical artifact or, again, might be consistent with what I just mentioned about our case rates. I don't want to take that to the bank yet, but they're super high, record high, never been this high before. Again, right now, statewide, 3 out of 10 people testing are going to test positive. Next slide, please. This is a new part of our dashboard, quick trends that Adam Anderson put up, which I think is nice because it lets you sort of look not at these 7-day rates, but it looks at it looks at the 7-day rates, but it looks at it incrementally over a 13-day span of time. And if you just sort of start at the top, Arapahoe County had a case rate, 7-day case rate on December 29th of 632. And we only take this one up through the 10th. I'm sorry, I didn't get a chance to update this one, but you can see we've increased almost 3-fold case rate wise in Arapahoe County. Similar story in Douglas County, and almost a 4-fold increase in Adams County, 461 up to 1556 during that same period. And you can see test positivity didn't treble or triple or treble or quadruple, but it at least doubled. Again, Adams 17.8, 30 up to 34.5, Arapahoe 18.1 to 31.7. So it's just been this rocket trajectory. Next slide, please. Let's get to the severity part of the story. Left is Tri-County, our 3 counties. Trends the lines aren't exactly totally parallel with each other, but we certainly saw that decline after Thanksgiving, and then we've seen an increase in all 3 counties since then. Right part of the graph are statewide data. I want to note that I've learned more precisely than I understood before why our hospitalization rates on our dashboard may appear to lag behind the state's data. I never really kind of got this through my skull, but the state is using EM resource to tell them about hospitalization statewide on a daily basis. So they can have close to real-time hospitalization data of COVID-related illness, whereas we have to go through CDERS, that's the disease reporting system. EM resource does not designate things at the county level. So we have to wait for that county level designation. And so we're going to intrinsically have this lag built in. When I talk about pivoting to the future, I think one of the things we really got to kind of get fixed is how to get hospital surveillance moving faster so that those of us that are trying to use these more important metrics of severity can have them more real time than we have now. The upper right on this is what the state posts every day, percent of all hospitalized. They're unvaccinated. It's actually gone down. It was in the 78 to 82% range. Since Omicron has taken over, it's gone down somewhat. I talked to Dr. Hurley about this. I think some part of this may be folks that are vaccinated and being identified as infected, but may have incidental infection. I'm going to talk about that incidental infection. I mean, not everybody who's labeled as a hospitalized patient with COVID is sick with COVID. And this is like so many things in COVID has gotten political. Our hospital statistics being overinterpreted because we've got all these incidental cases. I think that's what may be going on with this. And I'll show you a little more data about the incidental versus due to COVID cases in just a second. Next slide, please. These are the hospital census data on the left. So the slide before were new admissions. These are the people in the hospital right now. This is data from 2 days ago. So bear in mind our peak was, I think it was December 2nd, 2020, 1,847 patients in the hospital at one time in Colorado with COVID. We came close to that right before Thanksgiving. That's around the time we put the indoor mask mandate into effect. And we're not quite there yet, but we're getting quite close. In fact, I just scanned the data this afternoon from the state, and it looks like we may be there now. We may have caught up with where we were, at least in the pre-Thanksgiving peak. We're not yet at the all-time peak, but we are still moving up. The right hand is what I was really referring to about this incidental COVID diagnosis. Colorado is apparently one of the few states who are doing a relatively real-time assessment by sort of a medical records review process when there's a positive COVID diagnostic test, is to do some sort of review of the EMR to determine if this is a broken leg with a positive COVID test, or if this is something that really looks like it's due to COVID. Now, this is not precise because there are going to be some mixed stories. Somebody with a stroke, COVID can cause strokes. We don't really know whether somebody with a stroke who's got a positive COVID test has got atherosclerotic disease or may be having COVID-related clotting disorders. But Rachel Hurley's teams that's been putting this together has been able to show us that we had been at a baseline of around 80 to 90% of our cases had COVID and were in the hospital due to COVID. 10 to 20% probably had incidental diagnosis. That number is now shifted to 65 with COVID or sick from COVID. The 35% is incidental. I did want to make note, though, that while somebody with a broken leg with COVID is going to be less impactful from a COVID perspective on the hospital, there's still issues involved. Hospitals are really short-staffed. Everybody who tests positive has to be in isolation. Sometimes they can be cohorted in double rooms, but there's an isolation dimension to care to avoid transmission to folks that aren't infected. There can be potential additional diagnostic tests because you can test positive, you've got a cough, you've got a fever, you've got to be sure that somebody doesn't have actual disease from COVID. And there is some thinking, I don't think we can say this is definitive at all, that if you have underlying heart or lung disease and you have COVID, even if you came in with COPD, COVID potentially could complicate that underlying illness. Again, that's a hunch, that's not proven, but I just want to make the point that, quote, incidental, which sounds like it's like a piece of dust on the floor, is from a hospital perspective, a lot more than that. Next slide, please. Looking at hospitals another way, proportion of beds occupied by folks with COVID. These are data on the top from the Tri-County area. We're currently at around 25%. Now, this is both sick with COVID as well as incidental COVID, so let me be clear about that. But we're up really about as high. In fact, I think we're now higher than we've been in our three areas, even than we were last November and December. The bottom graph is taken from data that I haven't shown you all lately. This is our syndromic surveillance system that Tri-County began with a grant with Denver Health. Gosh, I don't know, Michelle, 10 years ago. This thing's expanded statewide, and there's a lot of syndromic surveillance we can do for both newly admitted patients as well as patients in the ER. And these are folks with, quote, COVID-like illness, CLI. It's not confirmed, it's just suggested by an algorithm. Folks that are either inpatients in blue or ER visits in turquoise, and you can't make out the colors, but you can probably see a slight color tone across the bottom. But the key thing to focus on is the orange line. That's the total COVID-related, either admitted to an ER or admitted to the hospital. And the point there is that these are not based on incidental positive tests. These are based on people who have an algorithm that is consistent with being sick from COVID. So I think you can see that while some part of that top line, up to 25%, is incidental COVID, there's a very similarly shaped line of people in ERs and being admitted to the hospital who've got COVID-like illness. Next slide, please. So how much capacity do we have to take care of patients has ended up, it's the key metric in our indoor mask mandate. And I think increasingly we're hearing many folks talk about this as being probably the most important metric we ought to be following. This is a dashboard Adam Anderson set up. It looks at the North Central region percent of staffed ICU beds available. And this thing goes back to the end of June when Delta hit. And, we were cruising between 20 and 25%. And then as Delta began to get more serious, we dipped below 10. And then we got around Thanksgiving and it dipped substantially below 10. And it got down as low as running around 4%. The good news is that we've seen some, albeit sawtoothing, some improvement in that. When this was on the 10th, we were actually at 10%. We've fallen below that today. We were at 8.5%. So we're still in a pretty tight place, but I do think that maybe we are getting slightly better. And I think that maybe getting slightly better is because Omicron is less serious than Delta. And we actually have seen small glimmers of improvement in hospital staffing. Even though those small glimmers of improvement, these are statewide glimmers, by the way, have been somewhat offset by sick staff in hospitals. Hospitals are experiencing the same sort of shortfalls that our schools are in terms of folks getting sick. So that's clearly impacting the staff bed capacity issue. But across the top there is looking at how many days in a row have we had 10%? And this only goes back 2 weeks, but we've hit a couple of days where we had 10%, but we're still looking for 10% for 14 days as the current metric for the indoor mask mandate. Next slide, please. So hospital systems are facing really big challenges. This was a piece from the Times yesterday, a couple of days ago. I think everybody heard we hit new national records. These are new national records of patients, both due to COVID as well as incidental COVID, but never had so many people with COVID in the hospital nationally before. We are, as I've already pointed out, not at that yet in Colorado, but getting close to it. I think you're probably aware that last week the state activated its crisis standards of care for emergency medical services. What does that mean anyway? What it means anyway is that when EMTs go out to see people, there are certain triage modalities they are allowed to follow. It also, I just learned the other day, means that if Hospital X is trying to transfer a patient by ambulance to Hospital Y, if the EMTs are on crisis standards of care, which they are, that transfer will have the potential of being delayed. So this crisis standards of care not only affects the pre-hospital situation, it can affect the inter-hospital situation. I have not heard of particular things breaking here, but it's a signal that this part of our healthcare system is stressed. I want to note that we have not yet activated, or it's not me, rather, it's the Chief Medical Officer, Dr. France, has not yet activated hospital crisis standards of care. Hopefully that won't be needed with the milder Omicron, but that is a tool that could be used, and we've already used this one for emergency medical services. Next slide, please. And I know Julie has school-age kids because she told me about it one this morning, and you know, our schools are really strapped. Oh, I'm sorry. I'm sorry. I had one more slide here. I wanted to mention we had the really good fortune last week of having a chance to have a press event. Mayor Hancock organized this. He invited all the regional public health directors. And it was terrific that we had a number of hospital officials as well. I think people like me, public health official, talking about how crowded the hospitals are, it felt like nobody's really listening to me. I'm not a hospital executive. I'm not a chief medical officer. So we had Dr. Price and Dr. Brumbaugh from Denver Health and Children's respectively, and we had Dr. Kathy Howell, who's the Chief Nursing Officer at University Hospital. And these, my colleague Dawn Comstock and Jeffco put this together just to give some flavor for the kind of comments that were being made. Again, these are the qualitative part of the story I've already told you, but it's so much more powerful to hear Kathy Howell. She had the quote of the day where she said something about, this is the scariest time of the pandemic for hospitals. If I said that, I may be technically correct. If she says it, it sounds real. Likewise, Dr. Price, likewise, Dr. Brumbaugh. And we particularly appreciated Dr. Brumbaugh being able to tie the mental health challenges that our kids are facing along with the hospitalization issues, and reminding all of us that a lot of what we've heard about the importance of mask wearing or how harmful masks are, he, I think, did a great job of correcting, really emphasizing the safety of masks for kids, the critical importance of them in keeping, at least somewhat reducing the infection rate in kids, and promoting in-person learning, which nobody needs to be reminded, really critical for kids' educational and mental health. Next slide. This is what I was trying to get at with schools. These are just web clips. Last week, a lot of schools closed down with the bad weather, but a lot of the bad weather closures were related to, oh, by the way, we also are really thin on staff. And maybe this will give us a day to catch up. None of our schools have gone totally remote, knock on wood. I think they've worked incredibly hard to do that. They're doing their own triage. We had some of the chief nursing officers in the schools say, look, we're going to have to take a pause at sending you some of the information you request about COVID and contact tracing, because we need to be in the classes because we don't have any substitute teachers. We are the substitute teacher for the day. Now, that's obviously not as good as having a trained science teacher, or maybe for science it would be, or a trained English teacher, but it's just an example of what the schools are going through to try to keep the in-person learning able to persist as long as possible. Next slide, please. Vaccines, the way out, sorta, kinda. This is where we stand in terms of our progress. The completed vaccination rate for our counties, Adams 75, Arapahoe 76, pretty good, not good enough for Omicron, especially since Omicron needs a booster, and our booster rates are really concerning. Booster rates in Adams County, 43%, booster rates in Arapahoe, 48%. Even Douglas, which has historically had higher rates, is still only around 51%. And the histogram across the top shows you that in spite of the Omicron news, we're just not seeing bulk blips in vaccination. I think we need to face the fact that with our current tools, we've sort of got about a 20% or so part of our counties, this is actually better than national data, who are just not being able to be persuaded to get vaccinated. And while those eligible for boosters, you would think, have already made the decision that vaccines are good, we're hearing lots of folks saying, gosh, if I need a booster, it must have meant the vaccines were bogus to start with. Why do I need a booster? Or my neighbor got Omicron or got COVID after a booster, they must not work very well. So we've got a lot of issues happening in the community that may actually cause us to stall out on boosters for folks who ostensibly believe that vaccines were worth it. But the nuance of explaining they're not perfect and they will need to be reboosted is turning out to be really challenging. And again, foreshadowing moving into COVID of the future, I think trying to address how we help our residents understand that one will probably need that periodic boost as things move around, I think will be really critical. Next slide, please. Age, I show you guys this time every time. Let's look at Adams, for example, 70-plus-year-olds, quite good, 87% completed, not as good for the boosters. That's a group I really worry about. Similar, slightly lower story for the 60 to 69. And then when we get below 60, particularly for the boosters, we begin to drop off. We drop below 50% for every age group in Arapahoe County below the age of 60. Very similar story in Arapahoe County, although we do have slightly above 50% for the 50 to 59-year-old group. We talked to Adams County this morning, as we do every week, sort of a weekly leadership check-in about ideas about what we can do to try to reach back to communities. Alex Kellogg, Michelle introduced her, fantastic to have her on board as our community partnerships coordinator, which means working with community partners on vaccine groups, and boosters are clearly one of our top priority at this point. I'd love to have as a secondary priority those who haven't been vaccinated, but I think the folks needing a booster who've already had the first 2 shots are probably the more persuadable group. Next slide, please. This is looking at breakthrough data. Adam and now Robin Hart, who's assisting Adam with all of our COVID data, sends you this every week. And so you've seen this, but the left graph is looking at the area under the curve since we had vaccines last year, just to give you some sort of flavor for how much of hospitalized and death severe outcomes are related to the unvaccinated. And while we are seeing more vaccinated people hospitalized and die than we did, say, 6 months ago, that still remains a small fraction of the overall morbidity. Now, I will acknowledge in the right-hand part of the graph, percent of hospitalizations unvaccinated by county, that percent is beginning to dip. And I don't know this for sure. Again, I was talking to Dr. Hurley about it. She's not sure either, whether some part of the apparent disease in vaccinated people are the incidental COVID infections. And they're incidental because although they broke their leg and had COVID, they've been vaccinated and so they don't get sick. I don't know if that's true. It makes sense to me that that may be part of the explanation. And although the death data for January are incredibly limited, you can see that we've been hovering at the 85% of those who actually die from COVID being folks who were unvaccinated. Next slide, please. I want to, again, thank Alex for stepping into her role rather, just when the Omicron fire hose got turned on and adapting so rapidly. This is sort of a summary of what we're doing across the counties with vaccine equity really remaining a North Star in terms of how we try to focus on that. We've had a lot of questions asked about, is there enough capacity in the communities? I couldn't get an appointment with Walgreens for 3 weeks. What's going on? We do know that some providers have had delays, but we do think that in all 3 of our counties, and certainly the 2 that we're primarily focused on, Adams and Arapahoe, there is sufficient capacity for vaccinations. Some of it involves having a private vehicle to drive up to a big vaccination site like Dick's Sporting Goods or Waterworld. But we do think that at least overall, there's enough capacity. We're now working on communication strategies in coordination with community partners to help folks realize if Walgreens doesn't have it, there are lots of other places that probably do. They may not all be the most convenient, and that's something we want to really be working on, but we do believe there's sufficient vaccine supply out there. We're continuing to work in the priority neighborhoods that we've talked about before, Brighton, Federal Heights, North Glen Thornton, Commerce City, North Aurora, and Sheridan and Inglewood. We are assessing if we have sort of maximized our progress in these neighborhoods with the current coordinated partnerships. I'm sure we could always do better, but Alex has raised the question of whether we may now begin to refocus in a cross-county way on a sector-targeted strategies. What do we mean by a sector? I mean things like working with a school district or multiple school districts to reach kids in schools, or working with housing authorities, not just in Brighton, but across the county with faith-based groups to see if we can replicate some effort in a broader way. And again, our priority efforts are boosters. We're certainly trying to reach the kids, particularly those 5 to 11, whose vaccine rates are increasing, but not increasing as fast as we had hoped. Particularly focused on long-term care facility residents, staff, and homebound residents. And again, really trying to up the game with our potentially under-vaccinated communities and under-vaccinated ethnic groups. Becky O'Gwyn is working with Alex on some new radio outreach strategies that have proven effective in the past, and we think need to be re-energized with some new messaging about boosters. Next slide, please, Lisa. These are Colorado state data looking at, this was like at the end of December. I haven't got any updated state data on boosters, but the goal was 75% of eligibles boosted by the end of January. And by the end of December, we were at about just under 50%. If you stretch that line out, we're not going to be at 75%. The right is a heat map looking at the density of unvaccinated folks. And guess where the darkest part of the heat map is? This is not necessarily rates, but these are unvaccinated individual people. So the metro area in particular, but Denver, Western Arapahoe, Western Adams remain very high priority areas in terms of not yet boosted folks. Next slide, please. Please, terrific. I mentioned long-term care facility residents. This really concerns me. Across the top is when we looked at the original course of vaccination, we did really, not perfect, but really quite good. 95% of residents fully vaccinated, 93% of staff. The staff vaccination was assisted by the fact that it was mandated. The first 2 doses were mandated. Boosters have not yet been mandated. And this is actually sort of an interesting experiment of what happens when you have actually a motivated group of people working in a high-risk setting who are required to get a vaccine versus not required. We've only got 30% of the staff in nursing homes boosted, or long-term care facilities, and we're still lagging on the residents. And you can see that the curves have flattened out in the last couple of weeks. Now, those were holidays, but that's still concerning that we've just, particularly for the residents, got to figure out ways of getting those levels up. Our long-term care facility outreach team is working with Alex's team to see if we can up our game with the state health department coming into nursing homes and doing more vaccinations. Next slide, please. Omicron. So I've sort of given hints, and you guys already know all these things. Highly mutated, spread hugely in South Africa, went nuts in Western Europe, pretty much all over the world at this point. Lots of unknowns in the beginning have turned into knowns. Definitely more transmissible. Definitely, well, there's still some folks who say, is it potentially vaccine-related immunity? But I think most people think it's almost certainly less severe. It's almost certainly less responsive to vaccination unless you're boosted. And even with boosters, it's probably not quite as responsive. Whether the boosted response is insufficient enough that warrants an Omicron-specific boost is still being discussed. The manufacturers are making Omicron specific boost, but they're not yet, the decision hasn't yet been made to use those. Prior infections probably provide less protection. I think one open question is whether or not, I mean, I know so many people with Omicron who've had it. And the question is, are we good to go? I think there's the notion of let's have an Omicron party and get it over with. And I think that's an area that we still don't completely know. And then finally, treatment options are definitely reduced. We talked about that a month ago. That's not any better than it was then. Next slide, please. This is pretty interesting. This is data that's taken actually from the Johns Hopkins website, and it's put together by a team at Oxford. And you can go in and play with this stuff for hours at a time to look at case rates and vaccination rates and hospitalization rates by country across the world. But I'm showing you this to give you some flavor for what they're showing for a number of countries about cases. And the bottom line is South Africa. And you can see that South Africa did go up in mid-December and then went down. It wasn't like a super sharp peak, but it's been a steady decline since then. I would draw your attention to the pink line that's sort of messed up in the middle, sandwiched between Spain and the US, and that's the United Kingdom. And I think the data are pretty clear that in most parts of the UK, not everywhere, but most parts, things are beginning to come down. It looks like maybe that's happening in Denmark. It looks like it is probably happening in Spain. It might be happening in Canada. These data can sometimes be lagged. But I think the point here is some places, France, for example, it's not really happening. The Netherlands, not really happening. Germany. But there is a sense that some places that got hit earlier are beginning to turn the corner. Next slide, please. These are data Dr. Herlihy pulled together. And what's interesting is across the x-axis is the days since the beginning of the Omicron surge. And on the very rightmost part of the that x-axis is 0. So your minus numbers up until about 80% of the way across, and then it's times 0. That's when Omicron got introduced into these selected locales, 10 days, 20 days, 30 days, et cetera. What's interesting, and where I put the red arrows, is what was seen at approximately around day 30 to 35 in Gauteng province, South Africa, and in London. And so around the same time, again, 30 to 35 days, you begin to see trends downward. Now, in the last 2 days, New York City and Boston have reported they think they're beginning to see plateauing cases. Boston's is based on wastewater, although I think yesterday the cases began to go down. New York's cases have been going down for, I think, 3 days now. I don't know whether what I told you about our counties is going to pan out or not. But the notion is that we ask, are we going to look the same as South Africa? Are we going to burn through this as fast? Or are they different because it was, by the way, summer down there and it's winter up here? And maybe our vaccination rates are higher, but at least this early data is beginning to suggest that we might be expecting something that lasts once it begins to really accelerate, something on the order of 4, 5, maybe 6 weeks. Next slide. These are some other, I call these emerging hints. This is just a collection of sort of things. Very interesting animal data. I haven't read it all, but the first one's quite interesting. It's a collaborative team of NIH scientists across the country working with a ton of different kinds of animal models who found that you've got this really interesting differential between Delta and Omicron in terms of how it infects mice and hamsters. Much more upper airway and bronchial epithelium with Omicron, and much more lower pulmonary tract, including alveoli, the lower part of the lung, with Delta. That's been one of the most solid clues about why in the world should Omicron be making people less sick. And it does appear to have some differential predilection for cells in different parts of the body. The idea being if it's in your alveoli in your lungs, you're going to get pneumonia more likely. If it's in your upper airways, you're going to get a bad cold. The article right below that's quite interesting. It's a fascinating evolutionary analysis looking at how mutations happen. And it turns out mutations in a coronavirus happen differentially by what host species they're in. And this team from China looked at about a dozen species and came to the very preliminary conclusion. This is not yet a peer-reviewed paper, but it's still very intriguing. Very preliminary inclusions that the kind of mutations that Omicron has is more likely to be seen in mice than any other species. So again, it turns out that the host in whom the virus is replicating may govern what sort of mutations happen. And the theory then may be that we know this is a zoonotic infection. We think it probably came from bats, but we know it can affect other animals as well. Mice, white-tailed deer, your family dog. And it looks like that mice, at least in this case, might have been a place where the mutations happen. I don't think it's like, oh, now we figured it out, but I think it just points out that variants in Omicron, or rather with coronavirus, may be challenging over time. And then the other article was simply to say, lots of hope about immunity. We don't know. I think one of the most important questions still to come is whether all of us getting Omicron is going to give us some at least intermediately lasting value. Next slide, please. I want to give you a little bit of an update from the School Public Health Modeling team. They put out a statement last week because they hadn't been able to really get enough Omicron data to do good modeling. And they had some tentative conclusions about Omicron is here, it's exploding, particularly in the metro area and the mountain resorts. We're almost certainly going to see record numbers. They said that on January 3rd, they were right. They said hospital demand is almost certainly going to increase. It's been increasing since just before Christmas. In other regions, hospital demand followed growth in cases. It could exceed prior peaks in Colorado. And given the highly infectious nature of Omicron, maybe as infectious as measles, the wave could be shorter, but higher, maybe more severe. Very high probability that many of us, Dr. Fauci and Dr. Woodcock said the other day, maybe almost all of us, I don't think really all of us will get infected, but lots of us will. Still the unvaccinated and immunocompromised at most risk. And their conclusions on January 3rd, watching early returns, was vaccination, masking, staying home and sick, and limiting contact in indoor spaces, especially if you're not wearing masks. That was January 3rd. Next slide, please. This is what Dr. Hurley, he shared with us yesterday, their updated modeling report. So they've updated estimates about infection prevalence, meaning how many of us are contagious at any one point in time. And we're now seeing numbers higher than we've ever seen, between 1 in 6 or 1 in 20, that is between about 5 and 16%. Most likely somewhere between 1 in 10 and 1 in 15. They expect hospital demand to grow. If we experience growth similar to South Africa, it will grow slowly and then level off, peaking at around 1,800. If it's more like London, it will accelerate, maybe get to 2,500 by mid-January, and then begin to level off. And if it's like New Jersey, which is experiencing an even tougher time, we may well go past 2,500. Lots of uncertainty, so hard to model a single trajectory. Their best guess is somewhere between 1,500 and 2,200. Remember, our all-time record during COVID was in the 1,800s. And the range of uncertainty means it could be as low as 1,400. It's higher than that now, so that's wrong. Or it could be as high as 3,000. If we are on the most severe trajectory, very short-term but effective non-pharmacologic interventions, NPIs, increasing transmission control could prevent us from exceeding hospital capacity, but it would have to happen really fast. And they later concluded that it would have to happen so fast that we'd almost have to do it tomorrow before we knew if we were on the severe trajectory. And we know that these, when I use the term NPI, I mean things that are mandated, the kind of things we've been through that I think there is weariness to implement at all levels, making the use of those to slow things down more challenging. They do note the clinical differences, people less sick, and that really the challenge is going to be staffing, and tons of people in the hospital. Next slide, please. Now this I didn't send you earlier because, as I said, I just got it from Rachel yesterday morning. This is looking at the different models. If we do the least severe model, we peak about January 8th at about 1,300 cases. We're past that. The next severe model was we peak on January 11th at about 1,400 cases. I think we're going to turn out to be beyond that, but we don't know yet. The next most severe model took us up to, that's more like the New Jersey situation. I think New Jersey is actually somewhere between the red and the purple. It's a little later, but it's higher. Again, 2,100 hospitalizations, more than we've ever had before, and not out of the range of possibility, although by no means a certainty, is something that's substantially higher hospitalization-wise than we saw before, over 3,000 cases. Next slide, please. Now, they would acknowledge we don't really have strong evidence we're on the worst case scenario course. If we were on the worst case scenario course, as I already said, short-term non-pharmacologic interventions, 2 weeks or so, would have to be very impactful to keep hospital demand below 2,500 beds. And we just don't know enough to predict. And by the time we do know enough to predict, it's probably going to be too late for us to do things that are probably going to be too distasteful to do anyway, like closing down restaurants or doing things that we did a year or 2 years ago. Europe is doing now. Nobody wants to go back to that. So we're between a rock and a hard place. And their conclusion is we just have to look at the data every day and sort of wait and see and be prepared for some uncertainty. Next slide, please. Therapeutics. So we've only got one effective monoclonal antibody. This was true. We knew it was going to be true when I talked to you guys a month ago. Now we know it's true. So we've got enough monoclonal antibody for only about 400 people a week in Colorado. That's 400 people a week, not a day. And Tri-County recently has been seeing something around 6,000 or 7,000 cases a day. Paxlovid, we have enough. That's the Pfizer drug that I think is the wave of the future therapeutically. It's oral. It's actually as or more effective than monoclonal antibodies. We've only got about 800 doses a week for the whole state. NIH has created some prioritization criteria to try to prioritize who should get these medications. There is another drug, molnupiravir, but it's only about 30% effective. And although it has fewer drug interactions than Paxlovid, the conventional wisdom among colleagues I'm talking to who are ID docs is it's probably just not worth using. So it's the molnupiravir supply the state's getting is not really being gone through. Important caveat for both of the oral drugs. Oral is fantastic, but the window of administration is shorter than monoclonal antibodies, 5 days. And if your test results are taking 4 days to come back, guess what? Your window of getting therapy is really tiny. And if you don't have your own doctor and your own doctor doesn't have the medication, guess what? Your opportunity to get the medication is really tight. So the 5-day window dependent upon a confirmed diagnosis that's not based on a rapid test is challenging. Next slide, please. Just a glimpse, you guys aren't going to be responsible, nor am I really, for making treatment decisions, but just so you know how it's looked, NIH came up with 4 tiers. Most important are immunocompromised patients, regardless of vaccine status, or unvaccinated folks who were 75 or 8 or older, or 65 to 74 with additional risk factors. Tier 2, unvaccinated people who were not included in Tier 1. Tier 3 are vaccinated people who've got high risk for severe disease, greater than 75 or greater than 65 with clinical risk factors. They recommend, but it's kind of ambiguous, non-boosted patients should probably be moved up the chart a little bit because they're at higher risk. And then finally, Tier 4 is anybody at risk of severe disease. That's who we were treating a month ago. We were dealing with Delta. So we've got 3 priority tiers. Now, the problem with this is not only do a lot of people not get treated, there's no easy way to allocate this stuff at a state level. So what's happening now is that the state's giving out different drug to different hospitals, and they're responsible for allocating it. But one hospital may get down to Tier 1 or even Tier 2 or 3, and another one doesn't even have enough for Tier 1. We haven't heard any returns as to how this is playing out. But you can imagine for something that's got this short a time frame for administration of treatment, how having too limited a supply of treatment makes triage really challenging. Next slide, please. This is now moving to the next topic, the topic that has been one of great concern to the board over the last 5-6 months, and I just wanted to give you an update on where we stand. As a reminder, you guys know this, but I think often in the public, it all gets confused. There are two separate mask mandates. We've been discussing tentative metrics about the school mandates with the board and with regional public health directors for the last couple of months. Tentatively, we had arrived at 7-day case rates per 100,000, less than 50. That's what CDC still considers to be moderate transmission for 21 days. And one of two vaccine metrics, either 70% of kids getting vaccinated or vaccines being widely available and accessible for 3 months, and we'll be at 3 months by February 8th. The state was having lots of discussions about modifying its school guidance in mid-December. And we didn't know when that was going to change. We thought that might impact some of decision-making about masking, and decided on a couple of days after Christmas to go ahead and extend our order without putting metrics into the order because there was so much uncertainty about what the state was going to do. That's where we stand at this point in time, with the order having been extended through the 31st. And as a reminder for the public mandate, our metric was the 10% ICU capacity for 3 weeks. This has become a topic of some controversy. Well, it's always been a topic of controversy, but what's happening as a result of this mandate is continued to be a topic of great discussion. Levels of masking do appear to have increased in counties with mandates based on the data Carnegie Mellon puts out in their daily updates based on Facebook self-described mask wearing. It is really, however, very hard to, with any degree of precision, use surveillance data for cases or hospitalizations to compare either before or after, or more problematically between counties, especially with Omicron, just how impactful the mask mandates actually been. There is every reason to think biologically the masks ought to work. Whether mandating them works is arguably a topic that is debatable and hard to really pin down. I would note that the mandates have been continued in the other metro counties, and they've actually been expanded over the last month. Several of the mountain resort communities have implemented mask mandates as they were experiencing the huge Omicron surges. Next slide, please. These are the Carnegie Mellon data. I think those were in what I sent the board, and basically all the squiggly colored lines at the top are Adams, Arapahoe, Denver, Jeffco and Larimer that did implement masking mandates, and they all pretty much saw about a 20 to 30% increase in self-described wearing within 7 to 10 days after the mandate was implemented. Less in El Paso and Douglas that don't have mask mandates. I will note that as Omicron has gotten worse, we have seen self-described mask wearing increase in both counties. And I think it's pretty obvious that as people see what's happening, they're looking for ways to protect themselves, mandate or not. Although the difference, once again, still in self-described data, is still at about the 20% or so level between those with and without mandates. Next slide, please. Now, the Arapahoe Board of Health members, I think, were at the meeting we had with Arapahoe County on Tuesday, or the update. We got asked to address a graph that was generated using CDPHE data, looking at cumulative, or rather incidence rates. We think these are weekly incidence rates. They're not cumulative. And the dip on the right part of the graph is not correct because that represents lagging data. But we got asked to say, gosh, look at this. Adams and Arapahoe, same as Douglas. What's going on here? The mandates may not work. And I'll be the first to say that there is no way for us to use surveillance data to definitively conclude success of something like a mask mandate, nor I think can we use it to definitively conclude lack of success. I think one of the problems is we've got an enormously different population mix in the counties. We know that variables that influence case rates, such as vaccination rate, testing behavior, and maybe most importantly, likely exposures based on population percentages that are essential workers, living in multi-generational households, using public transportation, vary by county. We also know that factors that impact hospitalization, vaccination rate, age stratification, comorbid health conditions, vary by county. Adams has got most risk factors, Rapo next, and Douglas least. So when we see no change at all, very hard to know whether or not it's due to the fact that we've got differences or whether, the mandate's simply not working. And while I would love to be able to perform a multivariate analysis that could take all these things into consideration, neither we nor CDPHEs had the capacity to do that. I will say the overwhelming scientific consensus remains that masks can reduce COVID transmission, especially if it's higher grade medical. There's some ambiguity about whether CDC is going to change its recommendations and more strongly recommend N95, KN95s, and surgical over cloth masks. And I think this is as likely to be true in Omicron as in prior waves, since while we know that vaccines don't work as well based on molecular mutations, there's no reason to believe that the beneficial role of masks, whether it's respiratory particles or aerosol prevention, is going to vary by molecular mutation. So I think that to the extent that masks can provide some proportionate value, they ought to be able to provide proportionate value with Omicron as well. But I did want to at least bring the Adams board members into this discussion because it's one that's been circulating in the community. Next slide, please. A few closing looking ahead remarks. We're going to be nervously watching the hospital situation through the Omicron peak. We're still stuck trying to fight the same battles on vaccines, messaging to diverse groups, increasing understanding about Omicron. Do we need an Omicron booster? The Supreme Court told us today that large-scale mandates as implemented by OSHA anyway are not going to happen. So I think that apart from healthcare providers, which the Supreme Court did say was legitimate for those receiving Medicare and Medicaid payments, national mandates are not going to be at least an easy part of the solution in the future. We're clearly going to be dealing with the booster battle, the 5 to 11-year-olds, getting them vaccinated. And obviously, we'd like to get vaccines for the 2 to 4-year-olds as soon as possible. We're going to continue to not forget, whether we mandate it or simply recommend it, the value of masking, the value of good ventilation, and encourage businesses to consider their own vaccine and testing passports. We desperately want more treatment. If we could get a ton of Paxlovid, I think that could easily become the third tier in what it means to deal with COVID in the future, the other two being testing and vaccination. I think going back to when Dr. Fielding was on our board and asked us at one of our meetings to speculate about the changing to, the normalizing of COVID, I think that's been a hugely important question. It's not just her, all of you have asked us that as well, but she was particularly prominent in asking it. And whether you call it exit, off-ramp, treating COVID like the flu, it's something that's being thought about in all quarters. CDC is doing a listening tour around the country now, trying to sort of get people's ideas. CDPHE's got a conversation going on about this. I think it's a conversation that needs to happen. There was a very influential set of articles published in the Journal of the American Medical Association last week. I'm going to talk about those in just a second. I do want to say, I've got to remind all of you, part of the reason we talked about flavored tobacco products is that I think the challenge for all health departments is trying to maintain our focus on other public health issues and their impact on health equity, whether they're ongoing problems like air quality, chronic disease, health impacts of climate change, the wildfire being a recent example, or whether they're pandemic exacerbated, behavioral health, food and housing insecurity, et cetera, et cetera. Public health departments do not have the luxury of not paying attention to this whole breadth of things, even though our infrastructure has been thinned out and it's challenging. Next slide, please. Dr. Samet publishes a weekly piece, views from the dean or something like that. He's been writing very thoughtful pieces on COVID every week. He referred to this paper that came out last summer about possible trajectories of COVID-19. I thought it was a pretty interesting way to think about it. One trajectory is we could have an ongoing god-awful pandemic with inadequate vaccination, new variants, high severity, terrible infectivity, and everything would be like the pre-vaccine era. It seems to be pretty unlikely. I think the question is it going to be more like scenario B or C? Transition to an epidemic seasonal disease such as flu, although they remind us here that There are anywhere from 250 to 650,000 deaths a year from flu. This is not a trivial matter. 2% annually of all respiratory deaths. And what flu is really something that is pretty much gone for part of the year. And then intermittently it can explode in sort of bad or terribly bad situations. Or is this actually going to follow the pathway of the other 4 coronaviruses that now cause common colds? Again, when we first came along, is how different is COVID? And it's really pretty closely related to these 4 common cold viruses. And is it going to get there? And then they outline a number of different questions that need to be addressed in terms of the epidemiology, virology, immunology. I won't go through those, but I did want to sort of outline these possible pathways. Next slide, Lisa, and I'll close out now with a couple of what I thought was the best of the JAMA articles, one by Dr. Emmanuel Osterholm and Gounder about a national strategy for the new normal of life with COVID. And I really like the fact that they begin by saying, in delineating a national strategy, humility is essential, because predictions have been proven wrong over and over again. That there's so many unknowns. The precise duration of immunity from vaccine or prior infection. Is it going to be seasonal, or antiviral is going to prevent long COVID? We haven't really talked about long COVID much, but it's an issue, a major health issue for those experiencing it. Or whether even more transmissible, immune evading, or virulent variants will arise after COVID. And we don't know. We don't know if COVID is what the future looks like or not. We'd like to believe it is, but I think it was somewhat of an accident if it really developed in mice, that it became more transmissible, which is to the virus's evolutionary advantage, but did not become more virulent. That could have happened, and it didn't, but it could in the future. Another part of the humility is realizing predictions are necessary, but they're going to be kind of educated guesses. And while models are helpful, they're not going to be mathematically certain. Stuff's going to evolve, the virus, the host response, certainly our data. Our tools are going to expand, and we're going to understand their limitations, just like the vaccines aren't perfect. And I think really importantly, COVID incidence, vaccine rates, hospital capacity, tolerance for risk, and willingness to implement different interventions will vary geographically. And national recommendations are absolutely going to be implemented, need to be adapted locally. And so they say that they think, as we look forward, it's really imperative for public health, economic, and social functioning. I mean, really, this has gripped society in a huge way the last 2 years, that our leaders establish and communicate goals for management, benchmarks for any restrictions that might be needed in the future. From my perspective, in some ways, maybe most importantly, investments in reforms needed to prepare for future variants and other novel viruses. And then, of course, not just sound bites, but some clear strategies to accomplish this. Next slide, please. They talk a little bit about redefining an appropriate national risk level. And they, like a number of other folks, are now acknowledging that in contrast to the Chinese preparing for the Olympics, where it's zero COVID has never been, and it won't be part of our equation. Either vaccine or immunity is lifelong, in contrast to chickenpox, let's say. Current vaccines do not provide sterilizing immunity. Sterilizing immunity is the buzzword, meaning you can nip the infection in the bud when it hits your mucous membranes and prevent it from establishing an infection. We have got non-human reservoirs of infection. And when we have non-human reservoirs of infection, which we did not for smallpox, and we don't for measles, but it was hard to eliminate measles, it's very, very difficult to finally eradicate an infection. The majority of infections are asymptomatic or mildly symptomatic, short incubation. So we got rid of smallpox using something called ring vaccination. Can't do that with COVID. There's just no way to identify me as sick today, vaccinate the next ring and the next ring. We know that fully vaccinated folks can get breakthrough infections. And, you know, taking all that together, new normal is not living without COVID. So it requires, it's going to understanding it's going to be part of the gamish of circulating respiratory viruses that include RSV in addition to flu. They actually suggest that, you know, we think really hard about measures that are not just pathogen-specific vaccines, but things that may be cross-effective, ventilation being at the top of the list. really thinking hard about ventilation systems in all kinds of public spaces. They also talk a lot about appropriate risk threshold, developing better metrics to measure peak weekly deaths, hospitalizations, community prevalence, acknowledging different tolerance for disease, hospitalization, and death among individuals and communities, and that the trade-offs, which have always since the very beginning been the hardest part of the equation. How many deaths are worth a business closing? How many deaths are worth avoiding a bankruptcy? I can remember sort of scratching my head and asking folks to help me think about this way back in April and May of 20. And you know, we haven't figured that out, and it's going to vary by community. And there's never going to be a perfect answer, but those are the sort of implicit trade-offs that we're making. And then if we can define metrics of a peak risk, weak risk threshold, that could be used to trigger policies for emergency implementation and mitigation and other measures. And the healthcare system might be able to rely on that threshold to plan bed and workforce capacity on both normal and surge conditions. Last slide, please, Lisa. And I did want to get to this part, which is they say, look, a big part of the solution, I mean, we said this after influenza in 2009, 2010, we've got to get prepared. We got prepared. We said this after anthrax. We got to get prepared. We really got to get prepared. And they talk about better preparation involving better data, modern data infrastructure, including real-time data on respiratory viral infection-related outcomes and immunizations, the ability to monitor non-traditional environmental measures through wastewater and air with our more traditional clinical and epidemiologic measures. They didn't say it, but my number one pet measure is hospitalization due to XYZ in a real-time way. I think that's achievable to get it. I don't know what it looks like. I don't think it's going to be simple, but I think that's something we got to start working on ASAP. They talk about the implementation of a permanent public health workforce bigger than what we have now, with the flexibility and surge capacity to manage both ongoing problems as well as emergencies. So this community health worker enhanced public health workforce that we've realized so richly the benefit of during the COVID vaccination effort could in the non-surge times be doing plenty of things. Immunization for other diseases, work on adherence to treatment for people with TB or HIV, both of which are big issues in treating these chronic infectious diseases, likewise diabetes, health screening, and particularly supporting vulnerable populations such as pregnant women and newborns. They also call very loudly for an enhancement in another part of the not really recognized as public health workforce, our school nurses, who have been like nothing other than superheroes vital during the COVID pandemic, who could be dealing with lots of stuff that's not being well dealt with, whether it's immunizations, asthma, behavioral health, and sexual health as part of a broader public health infrastructure. They mentioned interstate medical practice capacity, telemedicine, cross-state licensure, as well as, you know, give me a miracle or two, rebuilding trust in public health institutions and a belief in the collective action of public health. I mean, I don't know what the solution of this is, but I think it's fair to say when you look back at where we might have been at mythic times in our past, the greatest generation, World War II, we are really far away from being able to recognize and act together on a common good. I don't know what that looks like, but I do know that that is, frankly, it's important for all parts of our society, not just public health, but will be important for that. And they acknowledge this is not free. It's going to take a lot of resources, and it's going to take a lot of discussion about those resources. But this is the time to have that discussion when our economy has been so smashed up, impacted by COVID, to try to take those lessons to heart. I think that's the last slide, Lisa. Can you flip and see? Okay, sorry, too long, apologies. Happy to take questions.
No, thank you as always for that very thorough and thoughtful summary, and for your commitment to protecting the health of the citizens of our region. Are there any questions? Dr. Faywell.
If somebody else has questions, they might want to ask them. Jan usually does, or Julie or someone. Mine might take a little longer.
Okay, well, I actually had a question. I heard that the Biden administration announced on Wednesday that they were going to be providing schools with 10 million COVID tests every month to enable districts to keep classrooms open. And I'm sure you don't have any insight into when and how that's going to be distributed. I just wondered if there was some preliminary conversation about how that would be distributed, and would it be the Colorado Department of Education, CDPHE? I mean, or is this just a preliminary thought that just hasn't, reached to the point of how it's actually going to be implemented?
It's the latter. I mean, I've heard several interviews with Tom Inglesby, who's the new testing czar, and most of his answers of that sort of specificity are pretty vague at this point. So I think because I think testing is such an important pillar, it's important, but I don't know any more than that.
Great. Any other questions before we get to Dr. Faywell? No. Okay, you're on, Tom.
Can we go back to slide 35? The one that showed the spikes in all 3 counties?
Lisa, can you help with that? By the way,
Yeah,
I want to
just one sec.
while Lisa's getting there, Kelly Wiedenbach helped remind me that it takes a village, and the PIM team has got many people besides Adam and Robin Hart that are working on it. Please read their names in the chat. That they've received a number of awards over the pandemic, and what they've done is just nothing short of Herculean.
No, not that one, Lisa. John added a few others, and so it's the spike graph shows all 3 counties are at the same level, and the question is why.
38, Lisa. It's 38. That one, Tom.
That's the one. John, I'm not sure we can dismiss the graph because of differences between counties. We have at least 11 modalities for dealing with the pandemic. There probably are more. I just couldn't come up with them just offhand. But we've recently mandated only masks. Now, I think there are 2 sides to the issues on this graph. Using the county, multifactorial variations to explain the reasons without getting more granular, I think is questionable. There are way too many variables in this situation. It doesn't mean the graph is right or it's wrong. From the numbers of cases, it's obvious that whatever we're doing isn't stopping this variant of the virus. Short of locking down, it's spiking like an Atlas rocket. And the question is why? And we don't have the answer. A more accurate study for our 3 counties would maybe help answer some of the questions. It may not be entirely correct. It might not explain everything. But I think a study that would look at like individuals in 3 counties and track their positivity and case rates. And from the standpoint, I don't think you can mix frontline workers like checkout clerks at King Soopers who are walking picket lines now, or lawyers. You can't mix those 2 together and say, see, that it's a multifactorial, so it doesn't give us an answer. Well, the idea is to track people how about legislators and government employees who are not living in multi-generational homes. Get the factors a little closer together. That still has so many variables. It would still cause a lot of questions in a study, but at least we're not trying to take an entire county and matching it against another entire county. And tracking a single modality, it's interesting, but drawing conclusions especially absolute conclusions, I think is risky. Masking, and I'm a mask wearer all the time, masking makes intuitive sense because we know the vectors associated with the spread of respiratory illness. We've all seen those experiments where they have somebody dressed in black and all you can see is their face, and there's a black background and there's lights above and below, and they sneeze or they cough or they sing, and you see a shower of particles going out. And we measure the size of the particles. We measure the viral load, et cetera, et cetera. That's great in the lab, but when you take that out into the environment, it may not be the same. You may be sneezing into your hand, which you shouldn't do, in a room all by yourself. Then you come out of the bathroom, if that's where you were, and you grab the doorknob, and now you've left viruses there. The next person in gets them. We know that from the Japanese study, virus can stay on the skin for up to 9 hours. That person with the doorknob related virus now touches his nose or his eyes or something, and bingo, we've got an infection. There are so many variables here, we have to narrow it down. It's not like we're comparing apples to oranges, but we might be comparing Granny Smiths to Red Delicious. They're apples, but they're not the same. Also, mask wearing, as we can see, is not a uniform practice. I don't think we can 100% prove that the mask mandate is or is not producing the desired effect. But if the absolute 100% proof of effectiveness is the mindset or the standard that we're to follow, one might never seek any medical treatment because that standard's not attainable. You can't do that. You go to the doctor and they recommend a treatment. It may be great for 98% of the patients in that practice, but for 2%, it doesn't work at all. So these people who want us to come up with a black and white on whether it's masks or whether it's that graph that shows all 3 counties at the same, that's not attainable, and it's very difficult. But for those who are always questioning public health and what we're doing, you got to thinking, what if on the other hand, that graph that we're looking at showed Douglas County having a rate twice as high as Adams and Arapahoe? Would we be discussing multifactorial county variations? Or would we say, see, told you so, masks work? We need to put time and our resources into studies that help answer the questions. Instead, we have elected leaders setting up separate health departments and using funds and consultants, on lawyers. Meanwhile, we have tri-county staff resigning and leaving public health. It's discouraging to say the least. One of the other discouraging things is if you look back, and this is the difficult thing, in political spheres, you don't have to, you can always write it off to people don't understand what you did. But when you're in science and in medicine, you look back and you have to live up to what you said before. When we shut down the economy and the society in 2019, we did so for a number of reasons. One was to slow the spread of the virus. Well, that's relative, but yeah. The other thing we did was say that we were doing it to buy time to build healthcare capacity. Well, it's not bricks and mortar, it's people. We didn't put the time in to build up the resources of people. We did it to buy time to get PPE and vents. Well, that doesn't do you any good if you don't have the people who work in the hospital. And a fourth thing we did was buy time to grow testing capacity and supplies. How's that look when we've got lines in the parking lots that go for 4 hours just to get a nasal swab? Doesn't look like the approach has been real effective. I have to commend you for using the JAMA, the Journal of American Medical Association editorial. I think that should be blown up and posted and sent out and in any possible way communicated with the entire population. That tells you just what we're doing and why we're doing it and how befuddled we can be, even though we're trying to address the problem. As my term on the board, which began long ago, expires next month, this may possibly be my last meeting. That determination's up to the Arapahoe Board of County Commissioners. If this is the end of my time on the board, may I say it's been an honor for me to try to represent all of the citizens of Tri-County. Thanks for the time.
Thank you, Dr. Douglas. Did you want to respond?
Oh, gosh. Well, I'll begin by saying I can't predict nor say what the Arapahoe commissioners do. You've been an extraordinary, valuable member of the board, and I hope they take that into consideration as they make their decision. It's been a personal honor to work with you all these years. I think you made a number of really critical points in what you said. I guess I just want to endorse what you said. I'm sorry. One more thing. I guess we did use the 2 years to get better vaccines, although the testing situation is obviously disappointing. But I think you make a number of really important points.
Jan?
Hi, thank you, Kaya. I just have a question on that same graph. I cannot really read it well on my computer. So I was curious as to the dates on that when people were saying about, oh, masks don't work in school. But in the beginning, I was just wondering if we were seeing the numbers going down, but then Christmas hit where, let's face it, none of us went to family gatherings with masks on. And everybody was having gatherings and getting together, and no masks were probably being worn, which probably, along with the transmissibility of the Omicron, sent everything sky high. It's really hard because I've seen a lot of families get it these weeks right after Christmas. Some of them chose not to get tested because they didn't want to know they had it because they wanted to go to work, even though the people at work were positive. And it probably was a case of them. So I don't know how you reach people to understand, again, that it's not all about themselves, that we really have to get that testing done. And then we have to do the proper isolation to try to figure out if this really is working or isn't working, especially with the masks. Because I can't see that slide again, but
You want to pull that slide up, Lisa?
Yeah,
it'd be hard to read, Jen, but
no, that's okay. The dates were so small that even my glasses I couldn't. And
no,
I was
know.
wondering if that was showing any kind of trend towards what I was thinking what might have been happening, but because I couldn't follow it.
38, Lisa. There you go. Yeah, and maybe you can put it in display mode. Expand it a little bit.
And hand me a magnifying.
Yeah, it's really, Jan, this thing goes, I am pretty sure, from early August, but it could be June. I can't read it either. And it's my slide to early January. And it does not show when we implemented the mask mandate for schools on September 1st, but it does show that indoor mask mandate on November 22nd, 23rd.
Okay, so it is showing the spike after Christmas.
Oh yeah, and again, that downward, it's a spike that hasn't yet begun to recede. But yeah, it is. You're right. There's no question that when Omicron came in, it certainly blew things apart.
Well, and it's interesting what you said. People were, they had their own mask mandates in Douglas County, and we had them here, and people basically chose to follow them according to whether they believed that they should when they were in these indoor spaces. But I did see quite a bit more when everything came out about, oh, Omicron is taking over and Omicron is spreading really fast. It was amazing how you suddenly saw more people in, for instance, like a Costco or a King Soopers that all of a sudden realized that maybe they should be wearing masks. So I don't know how you reach people. I hope that this will do what you say, peak really fast and go away and not be a problem. But I think that the mask mandate was effective, except for when you hit a time like gatherings for Christmas and people coming in and out of town. I saw that, and I saw it rip through a couple of families, including people that had come in from out of town, and they all tested positive when one got it. So, it's interesting to see how that graph went. Thank you.
Thank you, Jan.
Thank you.
Are there any other questions? I'm sure we'll be talking about this more at our February meeting, and where hopefully we will have resolved the question as to whether there will be we've reached the peak and it will actually be a downward trend, or whether in fact the worst scenario will be upon us. So thank you for this very thoughtful and thorough presentation. Not seeing any more questions. So we'll move on to the Executive Director's report. Any comments or questions about topics? There was lots of really good information in the Executive Director's report as usual. Any questions or comments about the Executive Director's report? I did want to applaud Tri-County for once again getting national recognition for its award-winning work, and congratulations to Kathy Plummer for your congressional recognition. I think that's a true honor.
And given that Congressman Perlmutter won't be running again, it's particularly nice that Kathy got that.
For sure. Okay.
I guess just two things I'd like to highlight real quick. I know we're over is I appreciate MAME tracking on the employee status situation. And, we're really working hard. The board's decision to support the retention bonus, we feel like was just incredibly helpful, but there's a strong current, and we're going to, I just want to say again, you guys, I do all the talking, but we've got such an incredible executive management team that is playing leadership roles in all of this, not just Jennifer, but every single member of the team. I just want to thank them for their work in this space. And then I want to acknowledge that we've tried to share with you, and we'll continue to try to share with you, that the world is not all COVID. This is actually National Radon Awareness Month, or Radon Action Month. So I think about that now that been working in my basement for 2 years, and I haven't taken a radon reading. I probably should. So.
Thank you. Okay, I'll move on to the other items. Set the agenda for the February board meeting. I think all of you at this point have the tentative schedule for the topics that we'll be covering every month. In February, we scheduled an update for the Public Health Improvement Plan, tentatively focused on access to mental and physical health services beyond the topics that are listed, which would include a regular COVID update. Just let Julie Mullica or I know if there are other topics that you would like to include. Board member remarks. Did any of the board members have remarks they would like to make? Not seeing any. Just in closing, I'd just like to thank, as usual, our dedicated unpaid Board of Health members who volunteer their time and remain committed to keeping the citizens of our region as healthy as possible. And many thanks as well to the dedicated Tri-County staff who are responding to a crushing demand for testing and continue to assure as many people as possible can avail themselves of the COVID vaccination. So thank you again. Do I have a motion to adjourn?
So moved.
Is there a second? All in favor, say aye.
Aye.
Anyone opposed? Motion carries. Thank you so much. We'll see you again in February.